My name is Kristen Pruski, and I lead Sibley Foundation's team. It's my pleasure to welcome you here today to hear firsthand from some of Sibley's leaders. These sessions will be recorded and we'll send out the recording after the event. All participants have been muted. Please use the Q&A feature at the bottom of your Zoom to ask any questions to our panelists. We'll review them during the presentations and answer them after the physicians speak. Lastly, I wanted to thank each one of you, our generous family of donors. You've provided us with needed resources during this pandemic and throughout the years. Your support not only provides funds for the hospital, it also shows our caregivers that the community is supporting them. On behalf of the entire Sibley team, thank you. Thank you for giving so generously. Now on to today's talk. It's my pleasure to introduce Dr. Erica Richards. She's one of our experts as the chair and medical director of the Department of Psychiatry and Behavioral Health at Sibley. She's an assistant professor of the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. Thanks for joining us today, Dr. Richards.
Good afternoon. Working through the technical difficulties here. Today, it's my pleasure to be here to work with you. Today, I want to talk about a couple of things, and I'm going to take a moment to just make sure that everyone can see the slides, and we will get started. So I'm here today to talk about mental health and COVID. And while this is a unique setting in which we will have to hold the questions until the end, I hope that we have a chance to make this very interactive. It's really important during this time for us to discuss how everyone is dealing with the pandemic, and mental health, among other things, is one of the biggest subjects that has been coming up consistently since really February, leading into March and April, of course. So I want to talk a little bit about our goals for discussion today. And the point of this is to start a dialogue. Certainly we won't have all of the answers. Certainly we won't be able to give you all of the advice that I hope to share with you, but we want to start a dialogue about mental health in various populations. After that, we should discuss the impact of the pandemic on mental health. How is the coronavirus pandemic really affecting us? And are the things that we're experiencing unique? Are they different? Or are we all kind of feeling the same anxiety and the same worries? We want to talk a little bit about that. And then we'll briefly talk on treatment options with specific emphasis on how we can help here at Sibley. So there's a couple of components of mental health that we want to talk about. What makes up our mental health? What comprises that? And there's a few things we want to think about. Of course, we start with diagnosis. Diagnosis is important. Is this depression? Is this anxiety? Are we just adjusting to the times? And really talking through the diagnosis is important, not only for people to understand what they're experiencing and be able to put it into context, but also so that we can talk about treatments, interventions, and the like. We have to talk about behaviors. And with behaviors, there's many different things, but I'll hone in on a couple. And the first I would say is, of course, whether or not there's changes to our eating habits, whether or not we're changing the way that we are partaking in alcohol, whether or not there's drug use present. All of those behaviors certainly have to be adjusted, and life events. And of course, the life event that we've all been talking about is the pandemic. But in addition to that life event, the other components of what's going on in our lives right now. We've had people that have had weddings. We've had people that unfortunately have had deaths in the family. We've had kids that have graduated. We've had kids that have missed prom. And so those life events also are making up components of our mental health and how we're doing on a day-to-day basis. And then there's that discussion about interventions and what will really help us through this process. Before we go further though, let me just take a minute to talk about the symptoms of depression. And we won't belabor this point in the interest of time, but it's important to note that sleep changes are a component of depression. And that can be sleeping more often, or that can be that you're not able to sleep. You're waking up with worries. You're thinking about the next day. You're worried about what you weren't able to accomplish before you went to sleep. All of those things can really affect our quality and our quantity of sleep. Are you losing interest in things? You know, at first everyone was out and about and walking and saying hi to the neighbors, and now, you know, it's getting colder. People aren't as interested in doing those things. Now, certainly you don't have to do the same things every day, but are you losing interest in the things that you like? Guilt about things. I didn't cook today. I should have cooked. I didn't call and check on my loved one. I didn't call and check on my neighbor. All of those things, certainly partial guilt helps us remember to do those things for our friends and for our community. But is there this kind of persistent feeling of guilt about a lot of different components? Energy. Is there a loss of energy that's kind of going throughout day to day that's new for you? Changes in concentration, changes in appetite. Of course, we talk about psychomotor changes, and at its most severe form is the person that can't get out of bed. It's the person that can't eat, can't swallow. And after we rule out medical causes of that, we really want to try to understand, is this an indication of depression? And we should also talk about any thoughts of suicide, because there is help, and I want to make sure that people understand that that is a sign of depression, that is a sign of needing help as well. And so if I were able to talk about depression through the years, if we were able to talk about depression and anxiety through the years, then what we can see is that there's various ages and throughout the different stages where we have different risk factors and different protective factors for depression. So in our early years, certainly it can be these genetic risks. Are things passed down to us? Do babies have separation anxiety, that sort of thing. But as you go through the years, you look at, you know, age 40, age 50, a lot of what we're seeing now is that that's that generation where we're caring for kind of the older population, be it parents, be it aunts, uncles, loved ones that are older, but also sometimes caring for younger populations, kids, nieces, nephews, that sort of thing too. And we'll see a lot of different changes in depression and anxiety throughout the lifespan. When we talk about anxiety, talk about a generalized anxiety disorder, of course, there are other things besides generalized anxiety that can cause worry. But when we talk about anxiety, we're talking about this persistent difficulty controlling worry in a majority of the time. And I have some of the criteria listed there. Some of the things that people experience include restlessness, fatigue, decreased concentration, irritability. And that creates this distress, this impairment throughout the day. It doesn't go away. Somatic means body functions. I have a headache, I have stomach pains, all of those things can be how anxiety is manifested in some people, as well as the psychological symptoms that people typically attribute to anxiety. But again, remember that worry can vary based on your age group. So we have a lot of people in their 70s and 80s that decided to go out, to wear their masks, to be cautious, but they were going out a lot more than maybe the 30 and 40-year-olds were doing at that time. And we've got teenagers that sometimes feel that they're invincible and they're going out. So all of this can cause stress depending on the age group you're in and the age group that you're caring for as well. When we talk about the factors that influence mental health, there's a couple of things to remember. Of course, physical health, relationships, the socioeconomic status, as well as participation in meaningful activities, all affect mental health, as does discrimination, as does the pandemic itself. And when we talk about the coronavirus pandemic, there's a couple of things that are noteworthy about this time in our lives in particular. And number one would be isolation. Realizing that when this first started, people closed their doors, they closed their windows, and they stayed at home. And a lot of times, if we talk about, again, our elderly population, to keep them safe, we stopped going to visit or we weren't allowed to visit. And so there was increased isolation there as well. We didn't talk as much with our neighbors. We didn't visit family members a lot of time. And that itself caused more anxiety. It caused more mood symptoms in patients. This loss of identity. Who am I now? Am I going to work every day? Because that's what I'm used to, but now I'm home. And when I'm home, if I'm, a working parent, am I a parent? Am I working? And how do I balance these two? And if you're someone that usually would go out at lunch to visit with friends, all of these things that we identified as important components in our life have shifted a little bit. And it's important to acknowledge that. This dependence on others. Do I go to the grocery store? Do I ask my neighbor that's younger than me to go to the grocery store? Do I have the right mask? Do I need to wear gloves? All of these things that we had to think through in order to feel safe during this pandemic also contributes to our level of stress. Whether or not there's a loss of family and friends, this can be from the pandemic itself. This can be from arguments that happen because people have different viewpoints about the importance or lack thereof of wearing masks. And so there has been some grief, some adjustment to your relationship with your friends and family as well. All of it resulting, of course, in the increased anxiety and looking at this lack of ability to engage in self-care. So if you're someone that would usually say, okay, I need a break, I'm going to go visit family or go visit friends, I'm going to take a trip. The way that we engage in self-care has also changed during this pandemic. And so it's important to identify new ways in order to make sure that you are meeting your needs. If it's time alone, if it's time with friends, and we'll talk a little bit more about how to do that. In terms of these strategies that you can use, please remember to ask for help. You are not alone. We're seeing a lot of calls requesting therapy, requesting additional evaluations. And so there are mental health professionals, and in some respects, their ability to do evaluations and discussions virtually has opened up the realm of possibilities for people to get the help that they need. Try to fix your sleep patterns, try to get sleep. If you need help with that, that's when you want to, again, reach out to a professional. Diet and it helps with energy, weight, making sure you're exercising. I have this phrase, just say no. Certainly we want you to still kind of stretch your legs and want you to do things, but when you feel like you're being overwhelmed and overburdened by asks outside of what you're comfortable with, remember that it is okay to say no sometimes, and certainly lean on the friends and family that you need for emotional support and try to be there as much as possible for them as well. I'm going to briefly talk about treatment options. Therapy and medications are their own discussion, and so I'm not going to spend a lot of time talking about them, albeit to say that what we know is that that third bullet point, the combination of treatment options and including therapy and medications combined, a lot of times is when we do see the best results. So if medications are needed, that's one component. If therapy is only needed, that's a second component, but sometimes it's important to realize that both are needed. I'm going to highlight a little more about the ECT and TMS. So I'm going to skip that for now, but also reminding you that emergency care is available when needed. What we've seen across the board is that people are waiting to take care sometimes of their medical needs. Now that certainly can go for mental health as well as other aspects of care, but we're encouraging people to please seek the care that they need, including emergency assistance when necessary. And we'll talk a little bit about inpatient care versus outpatient care, because I want to highlight one thing in general, and that is how can Sibley help with this? And there's a couple of things that we have at Sibley I think is important for our community to know about. Of course, we have inpatient services. So our unit is called 7 West here at Sibley, and that is inpatient psychiatric care for people in crisis. Usually those evaluations happen through the emergency room, but we do have the ability to care for people admitted to the hospital that are in crisis. And if they are admitted ultimately for other medical needs, then we have the ability to consult, to go see them and to help them through if there's an additional psychiatric issue that has presented as well as a medical issue. And we have outpatient services. Again, we'll talk a little bit about electroconvulsive therapy, transcranial magnetic stimulation, which are two procedures that we can use to help treat depression. But we also have longitudinal outpatient care as well on a limited basis here at Sibley. So that means outpatient providers that can care for our surrounding community as well. In addition to that, Sibley's taking an active role in training medical, nursing, nurse practitioner students. So we're trying to train that next wave of providers so that our ability to care for our surrounding community lasts. We also work with social work interns because they play an integral role of caring for and treating our mental health issues in the hospital also. We're involved in the DC community in general. We have representation on the Mayor's Opioid Task Force. We have representation on a behavioral health collaborative that comes from the DC Hospital Association. And so Sibley is really on the front of trying to make sure that, in DC and the surrounding community, we are really caring for people with their mental health needs. And we've just started. We're excited to really participate in research, because understanding mental health is the way that we move forward with diagnosis, with treatment, with really being able to service more people. There's a few studies that we're involved in. One's related to ECT. There's another that's related to suicide, in collaboration with the National Institute of Mental Health, that we'd like to get started, which is really hoping to identify those that are still at risk of harming themselves in some way. I want to highlight this slide just for a second. There's no need to pay attention to a lot of the details, except the ages here are patients. And as you can see, we have an adult unit, so we admit patients anywhere from 18 years old all the way up to 96, I think is what I've seen since I've been here. And that's just to say that we are really, really trying to meet everyone's needs. There are young people that are being affected by this pandemic. This slide is not related to the pandemic, but there are young people now that we're seeing that are affected by the pandemic, as well as our elderly populations also. I do want to take a few minutes to talk about brain stimulation, and there's two concepts that I want to talk about. I have this up because I think a lot of the people on this call may have received this mailer a few years ago. This is when we were really starting to grow our brain stimulation program. This is a part of our electroconvulsive team, and these are the people that play a role in ECT and TMS. So I've used the acronyms a lot. Let me tell you what they mean. Electroconvulsive therapy is a safe, or ECT, is a safe and effective treatment that involves carefully passing a controlled electrical current that travels through the brain to trigger a seizure. It has been identified as a treatment by the National Institute of Mental Health, by the American Psychiatric Association, by the US Surgeon General. It works, and it is an extremely valuable tool in the treatment of depression and potentially in other psychiatric disorders as well. And it is often utilized, again, in our aging populations. Transcranial magnetic stimulation, or TMS, and this slide is actually taken from my colleagues in Baltimore, is a non-invasive method of brain stimulation that relies on electromagnetic induction using a coil that's inside of the hood you can see here, that's placed over the scalp in a focused area in the brain that's thought to play a role in mood. And so these are two treatments that we are able to provide at Sibley, and we're interested in continuing to grow these programs because we think they work, especially when people are either too sick or are not responding to potential medication treatments that have been tried. Just want to show you, of course, if we look at about 3 years ago, we were doing ECT. We've been doing ECT here for a long period of time. But if you look at the 2018, 2019 timeframes, we've grown this. We've been able to provide this service we're really excited about here at Sibley. Now, 2020 is a little bit different because of the pandemic, and we did temporarily have to halt some of our programs. Similarly with transcranial magnetic stimulation, we have a lot of procedures that we're doing here. And so we're really proud of the fact that we're able to get people better. One of the last things I want to highlight is a recent US News and World Report rankings that were released. And for the 2020 to 2001 best hospitals in psychiatry, I'll give you an idea about our rankings. So in order to understand this, you have to understand that this is based on the expert opinion of surveyed physicians. And what they did is they ranked hospitals, and those hospitals had to be cited by an average of at least 5% of psychiatric specialists that were surveyed. And those top hospitals that were named were ranked basically because psychiatrists in the US were asked where they would refer their patients and where they would feel most comfortable. And I'm proud to announce that Johns Hopkins Hospital is #1. And at Sibley, we have multiple providers here that trained either in residency or fellowship or worked at the Johns Hopkins Hospital, of course. So not only are we here at Sibley, but we really believe in using the appropriate standard of care to get our patients better. And we're excited about opportunities to grow these programs as well. This is my last slide, and I think it's just important. It's a little bit busy, but the point is to look at this middle area here where you can see kind of all the different colors. And what we know is that when we look at people that have symptoms of depression, sometimes they're very similar to a different disorder called dysthymia. Sometimes they're similar to people that have bipolar depression. Sometimes they're similar to anxiety, depending on which symptoms we're talking about. And so really the new wave of treatment, the new wave of what we want to target when we talk about treating mental health is called precision medicine. And what we want to do is to identify those symptoms, those qualities of someone's illness that may even transcend, that may even go beyond a diagnosis of depression. That may include people that have bipolar disorder, that may include people that have anxiety. But understanding those symptoms and what causes them gives us new hope for treatment moving forward as well. And so we're excited to be involved in a lot of the thought process that's going into that as well. So I think my time is just about up. So I want to thank you for your time, and I look forward to perhaps answering some questions when we get to the Q&A.
Thanks so much, Dr. Richards. We appreciate your presentation. I know I learned a few things, as I always do from you, and look forward to everybody to continuing to add your questions into the Zoom and the Q&A feature versus the chat. So aim for that little Q&A box. Now it's my pleasure to introduce Sibley's leader, Dr. Hassan Zia. We're so lucky to have him as our leader, not only because he's our president, but he is also has dual board certifications in general surgery and surgical critical care. He joined Sibley's team in 2006, and you can imagine with his clinical background, it's been a real asset for all of us at Sibley during this time. We're grateful for your leadership, Dr. Zia, and your time here today. So we look forward to hearing from you.
Great, thank you so much, Kristen. And it's really a privilege to join all of you today, and it's certainly a privilege for me to be at Sibley in this role. I'm going to share my screen. Just a second. All right, are you seeing my slides, Kristen?
We sure are, thanks.
All right, perfect. I just wanted to make sure you weren't seeing the preview. All right, thank you for this opportunity. I wanted to talk to you today about just a couple things. Talk to you about what COVID is looking like in our community today and at Sibley, and then really spend a little bit of time talking to you about how your support, how our community support has really enabled us to do some amazing things across this pandemic, and how grateful we all are at Sibley for the support that our community has provided to us. So this is looking at the daily average new cases in the District of Columbia going back to the beginning of this pandemic in March. Early in the course of this, we were seeing a very high rate of increase in new cases in the District of Columbia. And even what you see on this, this particular slide doesn't tell the whole story, because as many of you know, early in the pandemic, testing capacity was significantly limited. If we were able to test more people in the months of February, March, and April, we probably would have seen many, many more cases than we actually did. But nevertheless, over the course of time, our testing capacity has increased. We saw the rate of new cases significantly decrease over the course of the month of May and into June. That decrease is really attributed to all of the social distancing measures that were put in place as a result of the public health emergency and the state of emergency that was declared by the mayor's office and DC Health. And so closing of schools, enforcing masks, closing restaurants, closing bars, that really helped curtail the spread of this virus within our local community. It actually helped us to meet the metrics that allowed us to move into phase 1 of reopening of the District of Columbia in May, actually late May of this year, and then actually move from phase 1 reopening to phase 2 reopening that occurred at the end of June. A lot of the activity we saw in late June and early July in the District of Columbia resulted in a second little peak in cases that we saw sort of in the late July timeframe and into the first half of August. As things sort of settled down in late August and into September, we really saw the hospital burden of COVID decrease significantly. And then again, recently in late September and into early October, we've seen now a second uptick in the rate of new cases in the District of Columbia. And that is really a very much of a leading indicator. Typically when, and as has been in the experience in other areas of our country, like New York, like Wisconsin, once you see those cases, new cases increasing, the impact on hospitals usually lags by about 2 weeks. And certainly over the course of the last few weeks, we've seen an uptick in inpatient activity related to COVID. Over the course of August and into September, we had inpatient censuses of maybe 1 to 2 patients at any given time. We were actually able to close our COVID unit for a period of time in September. And then last week, we've seen an uptick in cases again, and have been caring for as many as 8 to 9 patients over the course of the last week or so, and we did end up reopening our COVID unit. This is the rate of transmission. So this would actually be the slope of the curve of new cases on a daily basis. And what this literally means is that for every 1 patient that's infected and has a positive test, how many additional cases will that 1 case generate? And so a slope of 1 or a rate of transmission of 1 means that for every person that's positive, they will in turn cause another individual to be positive. If you have a rate of transmission less than 1, that tells you that the pandemic will eventually end, that this will peter out over time. And if anything greater than 1 says there is going to be some continued spread of this within the community. We did a great job as a community in driving that rate of transmission to less than 1 in the April and May timeframe. A lot of the summer activity and outdoor activity and larger groups that started to gather towards the end of June as phase 2 reopening commenced, saw that number go back up over 1 again. And then again, more recently towards the end of September and the first part of October, we've seen that rate exceed 1 for a period of time as well. And again, we're seeing the downstream impact of that at the hospital level. This is looking at the rate of positivity or positive tests within the community. So this is very much a product of the testing capacity. We have had less than 5% of people test positive over most of the course of the summer and into the fall. And again, that is a very important leading indicator of what's happening in the community. So we really want to see that positive test rate of less than 5% and ideally less than 2% persist and continue. This is looking at the utilization of hospital capacity across the District of Columbia. So there's another slide right after this that tells a better story of how that capacity is divided. But essentially what we're seeing is that overall, the inpatient capacity utilization across all District of Columbia hospitals is at about 80%. The reason that it was much lower in the March, April, May timeframe, as many of you know, we essentially stopped all care other than the care we were providing for COVID patients and the care we were truly providing on an urgent and emergent basis. All elective surgery across all the hospitals in the District of Columbia stopped in the late March timeframe and did not start to resume really until the June timeframe. So the impact and the reason why we're seeing more utilization now is because we're really caring for both COVID patients and also providing that routine care that we would perform on any other day of the week, any other time of the year. And that is really pushing the limits of our healthcare delivery system right now. This next slide actually does a great job of showing how that hospital capacity is divided up. So here, the blue line is, again, across all DC hospitals. current inpatients through October 26th, and you can see the number of COVID patients treated at hospitals has been varying between 80 to 100 across the District of Columbia over the last several months. The red line is non-COVID patients, and as you can see, that number, as we started to reopen care, start to resume elective surgery, and non-COVID care over the summer months has steadily increased and is continuing to tick up, particularly as we reach times of the year that are historically busy, whether it's from an elective surgery standpoint or just due to cold and flu and things like that. If you look at the total bed capacity in the District of Columbia, so normally, under normal circumstances, there are about 2,500 beds, give or take, available across DC hospitals. As we started to collaborate and to respond to the need for increased capacity to deal with COVID patients, we were able at Sibley and really at all the DC hospitals to develop a surge plan such that we would take care of more than our typical capacity of patients at our individual hospitals. At Sibley, that meant using non-traditional spaces for patient care. So as an example, at the peak of the first surge of COVID, we were using our recovery room for our main operating room as a COVID ICU, and we were taking care of upwards of 12 to 15 patients on ventilators in that space. Across the District of Columbia, there were about 1,000 incremental beds that were identified through these alternative sites of care, like recovery rooms, like using semi-private rooms. And so as a community, we were able to surge to care for up to 3,500 patients. With the numbers that we were seeing early in the pandemic, it was really clear that 3,500 beds across DC may not be enough. And so in working with DC Health and our partner hospitals, there were additional hospital beds that were stood up at the DC Convention Center, and those beds continue to be available at short notice if we were to experience another surge at a community. So those beds were set up in increments of 500. So there are 500 beds currently set up at the Convention Center, and potentially could surge to an additional 2,000 beds above and beyond that 500 in a true public health crisis where we were fully at capacity at all of our hospitals. This is looking at the percent of hospitalizations that are COVID positive. Again, during the March and April timeframe, we essentially stopped all non-COVID care, all elective care, and almost 25% of the patients that we were seeing were related to COVID. And that number has come down nicely over the last several months. So I want to shift gears and just talk a little bit about the support that we received across the pandemic, and really, again, thank everyone on this call and really express our gratitude to the community for what we were able to do across this pandemic. So many donations of masks, of respirators, of gloves, of other personal protective equipment. We had tens of thousands, literally tens of thousands of homemade cloth masks that were provided to Sibley, and thousands of meals that were donated to our workforce and to our hospital staff across this pandemic. Literally 30,000 meals were provided to the hospital from so many different sources, everything from large restaurants to individuals cooking in their home. We were able to, through philanthropy, support our workforce, as many of them had significant transportation needs that began to impact their ability to come to work across COVID. So many of our staff take buses, use the Metro transit system to get to work, and with the shutdown of Metro, both buses for a period of time and certainly curtailed schedules for subways, had a significant issue with getting many of our staff to and from work. And we were able to use, in partnership with Uber and Lyft, really utilize those services to help support our workforce and get them to and from work safely. Our Sibley Senior Association is a very active population. There were so many programs that we had for them on our campus. Certainly that's a population of patients that is certainly highly vulnerable to COVID, and not a population that we wanted unnecessarily coming to our campus. We were very quickly able to stand up a number of different digital program solutions for them so that they could remain engaged with us, but not have to physically come to our campus. This number of telemedicine visits has actually grown since this slide was put together, and we've actually completed our 25,000th telemedicine visit since the start of COVID. This was very much related to the support we received from our community. In many cases, we had to provide video cameras or other devices to our nurses and to our physicians in order for them to be able to complete telemedicine visits. But this has been a real success story across the pandemic. And not only are we providing testing for our patients, but we're providing daily weekday testing for our community at Sibley Hospital. We see probably 150 to 200 patients come through our testing tent on a daily basis, and much of that has been supported through Philanthropy. Early in the pandemic, as we stopped routine operations and redirected or repurposed staff to take care of really very sick and complex COVID patients, there was a tremendous amount of cross-training that we did for our nursing staff. So we had surgical nurses, PACU nurses, nurses from all across our campus taking care of COVID patients in ICUs and on floors across our hospital, and really the ability to get them trained to do care that was beyond their typical scope of work on a daily basis in many of the outpatient areas. That was something that we were really able to support through much of the support we received through Philanthropy. We were very fortunate in that we were actually able then to give back to our community across this pandemic. We provided over close to 50,000 masks for seniors and families and our essential workers across the District of Columbia. We provided nearly 40,000 surgical masks, gloves, and other PPE to many of our community-based organizations and partners, federally qualified health centers across the District of Columbia. And then we also were able to provide almost $120,000 to our community-based organizations to address some of the health disparities that really became unmasked across the COVID pandemic. So lots of great things that we were able to do and able to support our community. But again, it all starts with the support that we received from many of you and from our community. And then just to speak to some of the ongoing costs related to COVID that we're continuing to experience. So we now screen every single patient, visitor, or vendor or family member that comes to our campus at each of our hospital entrances. This is something that's a significant business process now. That wasn't something we did pre-COVID, and we continue to support that. As I mentioned, we continue to provide testing for our community on this campus through our testing tent. And then we have continued needs to support our workforce and their many challenges across COVID. So as schools haven't reopened, there is an increased need for childcare as parents have to make choices between coming to work or staying with their children at home while they're not in school. Certainly many food needs for our staff that we're thankful to be able to support, and then many programs just to deal with the stress and other burdens of the pandemic on our workforce that we're putting in place to support their overall health and well-being. So again, this is my last slide. I wanted to once again thank everybody for the great support that we've received from all of you, and would love to be able to answer any questions related to this or really any other topic that you may have. So again, thank you for your time.
Thanks, Dr. Zia. Dr. Richards, love to invite you, there you are, to come back on. Thanks so much. We appreciate your time, Dr. Zia, and sharing that information with us. So we've got a few questions in the Q&A. This one, I will start with you, Dr. Richards. Are you doing any work with DC's police to assist them with training?
At this time, we are not working with DC Police for training. We have done a few seminars that we as Sibley and Hopkins have been involved in to open the dialogue and to start thinking about what's needed and how we move that discussion forward, but we're not directly involved in training at this time.
Thank you. Either of you, maybe we'll start with Dr. Richards. This question is, I see no end in sight for COVID-19 and I'm in a vulnerable population. How should I help to cope with this?
That's a tough one. And I think that one of the ways I have heard the pandemic described has been it's a disaster of uncertainty. And so what that means is that, there's this great risk of psychological stressors. There's going to be a need to deal with that fallout because there's ambiguity. There's something that's causing death. It's an unknown duration. And really nobody's clear about how to avoid it fully. We know things that we can put in place to help. And so to the question, there's no end in sight. How do I cope with this? And this will go with a couple of different answers. But I think at first, as stated, we kind of just backed up and said, nobody in, nobody out. This is my safe space. But now I think it's important to open the dialogue, to have a discussion with the people that are in that inner circle, with family and with friends. And if you all are like-minded, meaning if everyone's wearing a mask, minimally socializing with others, able to social distance when they do things, then those are people that you should at least start in a safe way to open up to, because we are seeing the impact of isolation on people in terms of mental health as well.
I agree. I couldn't have answered that any better than Dr. Richards. I think it's such a balance, and we really have to deal with this in a much more upfront way at Sibley, because we have, as part of our campus, an assisted living facility in Grand Oaks. And we have put so many processes in place to help keep the residents of Grand Oaks safe across COVID. But it comes at a great cost, because we have essentially isolated them from the things that are most important to them. And it is heart-wrenching, on the one hand, to know we're responsible for their safety and to ensure that their environment is safe, but to not be able to see your loved ones and interact in those ways that are so socially fulfilling, it is absolutely heart-wrenching. And I wish I had a good answer to that question. And it is a balance. And I think in these times you do kind of rely on that inner circle and your family, and really try to think of all the different channels you have to connect and communicate. But it is very much a very difficult balance to strike.
Yeah, I was recently reading an article that was saying so much of our lives is tied to the future, and with the future so uncertain, whether it's planning a vacation or if you have to have a hospitalization or a surgery or some birthday or something special, and the toll that's taking. Thank you both. A question came in targeted for Dr. Richards. Any recommendations on how to help younger children, specifically elementary age children, deal with the stress of COVID, remote learning, and social isolation?
Oh goodness. Okay, so
that's a lot.
Well, it's a lot.
For parents.
It's a lot for our ears. It's really a lot for us to deal with at home. And so there's a couple of things that we need to do in general. And at first, it's always to remember that the children are going to feed off of what we're saying and what we're doing. And so it's important to send them a message of safety and a message of, as much as possible, that things are going to be all right. And the example that I will give is virtual learning. I know some private areas and in some places in Virginia are starting to go back, but in general, having a discussion with your child's teacher about extensions, about we're getting through this as best I can, about I can't help them through the day because I am busy, because I am doing things. Not to say you're not prioritizing your child, but if you're stressed out about getting the math assignment in by midnight, then they are going to feed off of that. And what we're seeing is that the teachers are doing their own struggles, because some of them are dealing with this dual diagnosis kind of reality as well. So opening up the conversation and really stressing less about the deadlines is going to be important. We have a saying sometimes that pandemic rules means no rules, right? Can I play video games right now? Maybe, if that's what's needed. And so certainly rules are important, but knowing when to stretch them, when to relax them a bit, I think will help everyone, including the children, get through these times as well.
Thank you. I know for those of us who have school-age children, this is a constant and ever-evolving topic. Somebody has a little bit of a technical question here. They have a patient with a seizure history who's bipolar with hospitalizations. Is TMS an option for them? Is there anything broadly that you could share on patients with a seizure history and TMS?
So in general, a lot of times we follow standards that that are generated through different payers. In general, having a seizure history is considered a pre-existing condition that's not included in the ability to participate in TMS. So right now, because there is a very small risk of seizure associated with TMS, if there is a history of a seizure disorder, they're not candidates for TMS at this time.
Perfect. Somebody talked about maybe people who, Dr. Zia, maybe you can help answer this question. People who originally had COVID that are having COVID again, or is it the resurgence of COVID? Are they being re-diagnosed? Any insight into that?
No, I think they refer to them as the long haulers, and you know, from what we hear about this is that there are patients that have persistent, protracted symptoms from COVID, whether it be continued fatigue and weakness, whether it be persistent fever, persistent cough. I don't have a lot of experience with those patients. We've certainly seen some patients that have had repeated visits to our emergency department and readmissions due to ongoing symptoms. It tends to be in a younger population. The thought is that this is really an immune response to persistence of viral antigen in the body. But I think it's being accepted as a true phenomena that there are people that just have these very protracted courses. There's nothing that I'm familiar with at this point that is being contemplated as a particular treatment for that, but I'm sure that is going to receive more attention.
I'll end with one final question that we received. It was the topic of burnout. So it's hard to believe we've been in this now for 7 months, and people are feeling, as the holidays approach, and are feeling quite burnt out, whether they're balancing all the different things that we've talked about today. Any tips for folks as we head into the holidays from maybe a COVID spread perspective, Dr. Zia and Dr. Richards? Maybe any tips that you could provide on how people can cope with kind of this burnt out feeling that a lot of us are having?
Absolutely. So from a COVID perspective, I wish I could give better news, but I think it is important to be very mindful around social distancing, around avoiding large gatherings. Certainly wearing a mask we know is helpful despite some of what you all hear in the media. These are things that really, really help drive down the rate of transmission in our community. The data doesn't lie, and it's very clear that change that we saw in the April-May timeframe with regards to new cases and transmission of the virus is very much tied to the mitigation efforts that were put in place, and often are not easy to deal with, right? Particularly 7 months into this. But I would just encourage everybody to be mindful, make good decisions, make good choices, and those things that can be avoided. We should really be very thoughtful around those things.
And Dr. Richards, any tips on heading off burnout during this time?
Absolutely. I think to even continue Dr. Zia's statement, remember that, a lot of times we have to be future oriented. We have to think about what's coming next. This will end. We will get through this. And so remembering that we still all have to do our part is really important, because that's the number one thing to ending the burnout is getting on board to really do our part to help end the pandemic. And yes, there are other things that scientists have to do. And yes, we're waiting on the vaccine. And yes, we're trying to figure out, the treatments that are appropriate. But in addition to that, remember that goal that we're all leading to. So that's the first thing. And the second thing, in order to avoid the burnout, and this may be hard for those on this call, I think it's hard for a lot of people in general, is to also, this imaginary line is the bar. It's okay to just creep it down a little bit. And that means a couple of things. That means certainly your career may still be important to you, but finding ways that you can take the breaks, finding ways that you're getting up and walking and not sitting in front of the Zoom meeting all day. All of those things are still important. They don't have to be separate. You don't have to give up your career because you're taking a personal day. You don't have to give up your career because you're going out for a walk. And so really making sure that you're integrating those things into your day will be important for moving forward. And just remembering that there is help available. And if those interventions aren't working, then there's other options. And making sure that you reach out and ask for help is another key factor.
Thank you so much to you both, and for everybody who joined us today. As you exit this webinar, you'll get prompted with a really quick, about 3-question survey about topics that you might be interested in the future. So we hope you'll take some time to give us feedback, because we know there are so many Zoom meetings lately, but we hope to provide you through this Sibley Speak series with some information and education that can be helpful to you and your family. As a reminder, we will send this recording out to you in case you want to share it with anybody in your network. And to those on the call that have supported us in all of the different ways that Dr. Zia mentioned, but have also been long-term supporters of Sibley, we're very grateful. It boosts the morale of our team to see all of these donations flood in, and for people to know that you're watching out for them. So we just want to say thank you from the bottom of our heart. And thanks to Dr. Zia and Dr. Richards for joining us today, as well as all of you. Have a great day, stay safe, wear your mask, wash your hands, and stay physically distant through the holidays. Thanks so much.
Thank you, everyone.